and Metro North Health. But today I'm here as a Chief Investigator on the Wise of Wounds Centre for Research Excellence, which is a National Health and Medical Research Centre funded research centre that is based at Griffith University and led by Professor Wendy Shaboya, and with collaborators in many other institutes and hospitals around Australia. So firstly, I'd just like to acknowledge the traditional owners of the lands on which we're all meeting today and acknowledge their wisdom and ongoing contribution to healthcare and education and learning. So if you would like some more information on the Wise of Wounds Centre of Research Excellence, if you go to Griffith University's website and just go in the search bar and put Wiser Wounds, you'll find a lot of information. Essentially, we were set up to develop research evidence for mainly hospitalised patients with either surgical wounds, pressure injuries, or wounds associated with the insertion of vascular access devices. I just want to let you know that this session will be recorded today, hopefully by not me, because I don't have the button to record it. Yes, Helen Liu has started it. Thank you very much, Helen. We're going to have some excellent speakers today to discuss with you the release and implementation of the Australian Commission on Safety and Quality Healthcare clinical care standard for the management of peripheral IV catheters. So it's very topical, very important, and we have some wonderful speakers today. We'll have two speakers and then a panel, and we will have time for questions after each talk. Please pop your questions in the chat or raise your hand if you like, and Stephanie will be trying to help me keep an eye on that so we don't miss those questions. So I'd like to introduce our first speaker, Professor Samantha Keogh. Professor Keogh is a critical care nurse, both adult and paediatric, an established researcher and a professor of nursing with QUT. She is passionate about advancing the professionalism and science of nursing and demonstrating its impact in modern healthcare. Professor Keogh is a senior researcher with the Centre for Healthcare Transformation, as well as the Alliance for Vascular Access Teaching and Research. So I'd like to invite Sam to take us forward. Thank you, Sam.
Thanks, Claire. Thanks for that introduction, and thanks to the team for inviting me to talk about this. And it was a team that was involved in this. I'm just here to present some background to what led up to the standard and how the standard was generated, and talk a little bit about what's happened since. And then it'll be interesting to hear a bit more about that from Claire, and then especially interested to hear the health provider perspective and the consumer perspective from our other speakers today. So as Claire said, we're going to talk about the development of the clinical care standard. And just as a bit of a background, though most of you who are already on the call have probably come to this space because you already understand the importance and prevalence of IV catheters. But just to recap, 90% of patients that come into hospital will have some sort of IV experience, and about 70% of them will have a peripheral IV, and anything from 30 to 80% might need a central venous catheter, and a number of people may need some form of IV access, even just for blood sampling. So as you can see, intravenous access is the most common invasive medical procedure in modern medicine today. And it's essential to provide important medications, fluids, blood products, and monitoring. And a number of seminal papers have quantified that about 2 billion peripheral IVs, and it's growing all the time, are used globally each year, compared to about 5 million specialty catheters and central venous catheters. But before we talk about some of the issues and the challenges we've got, I really do want to celebrate that, that we stick plastic tubes in people's veins and we deliver important drugs and fluids, and that's just really transformed the way we can look after people. And I really do think it is important to celebrate that and all that that brings to our healthcare. And when we put IVs into people, we want to make sure that we're putting in the right device by the right person the first time, and make sure that that device is maintained without complications for the duration of treatment until its removal. And for many patients, that is the case, but for almost equally as many, that's not. Now, a lot of the research into vascular access has focused on reducing infection because of the serious consequences of that. Overall, the PIVC bloodstream infection rate is very low, about 1.1% or less than 0.1,000 per catheter days. But although that's very low in prevalence, if you consider the volume of IVs, that still might be a significant number of people that are having likely preventable infections. But overwhelmingly, the biggest complication with IVs is failure due to occlusion, dislodgement, infiltration or extravasation, and phlebitis. And consistently, we're seeing in studies that it's about a third of all IVs in adults and children are failing before the end of the prescribed treatment. So we wanted to, as a group, as a collective of researchers and academics and educators, get together and see if there was an overarching document that could support and advise clinicians in optimising the PIVC insertion and care. And as luck would have it, we have a national body called the Australian Commission of Safety and Quality in Healthcare. And in addition to their overarching national statements, they support them with a clinical care standard, which lists a small number of quality statements that describe the care patients should be offered by health professionals and health services for a specific clinical condition or defined clinical pathway. And we did think that the insertion and care of a peripheral intravenous catheter aligned with that. And this is an example of what the sort of statements they had before for other health conditions. So we lobbied, stroke annoyed the Commission to try and make them more aware of this issue. And eventually they responded with a smiling face and let us leverage and borrow their very systematic and inclusive process to generate a clinical care standard centred on peripheral intravenous catheters. And this slide gives you an idea of the very systematic and inclusive process that we were able to leverage off. It could have been we were often asked as a research group or as a national society whether we could generate the guidelines, but really for it to have meaningful impact. And these standards included in hospital accreditation, we really wanted to leverage off an independent national body. So as you can see, it's quite comprehensive. It started around the end of December 2018, and there was several months of knowledge acquisition, and then they determined the scope and the key components of the care, and all the time they're engaging key opinion leaders and leading researchers, as well as healthcare providers throughout this process. And as you can see, it took the best part of nearly 2 years, not quite. But of course, early 2020, the world was consumed with COVID. But prior to that, the bulk of the guideline development, the standard development, was conducted. And to inform that knowledge acquisition period, the Commission itself did a rapid review, and the Australian Vascular Access Society, that most of us were involved in, led a review, and KP Health in Tasmania, they also led a review centred on infection. So I'll talk to you a little bit about the AVAS review. So we did a review of leading guidelines, both national and international, and we also looked at the latest trial evidence at the time. And so 18 guidelines from professional colleges and membership associations and guidelines agencies, as well as state health authorities, were identified via a systematic search strategy, and they were appraised on their scope, quality and rigour using the AGREE tool, which has specific domains and assessment items. And most of the guidelines were ranked very low against the tool, particularly in the area of rigour of development. So that was disappointing, and we were obviously hoping to improve on that with the national standard development. There are a number of similarities between the guidelines, including adherence to basic infection control measures through maintenance of hand hygiene and aseptic technique, skin decontamination prior to insertion, and ongoing assessment. But the main difference related to an escalation pathway for patients with difficult intravenous access needleless contamination and flushing frequency, and device replacement schedule. When we looked at the trial evidence, in total, 40 trials were identified and appraised, and data was extracted and meta-analysed where possible or summarised narratively. The majority of trials evaluated different insertion practices and products and predominantly focused on the merits of visual aids, either ultrasound or near-infrared, and analgesia to minimise pain on insertion. Studies addressing post-insertion care evaluated the impact of different dressing and securement techniques, some flushing to improve patency, and device replacement schedules. So let's unpack some of the main interventions and outcomes. Predominantly, as I said, the studies focused on insertion. Overall, there were about 27 studies, and they focused on first insertion success and time to insertion, with secondary outcomes talking about failure, infection, dwell time. And the interventions they largely evaluated to influence that were ultrasound guidance, near-infrared and guide wires, plus different aspects of catheter design, insertion site, the inserter or workforce model, and analgesia. And the asterisked interventions are ones we were able to do a meta-analysis on. As you can see, compared to insertion, there was less than half the number of maintenance outcomes explored, and the primary outcome there was always peripheral intravenous catheter failure, with secondary outcomes being infection, dwell time, and the patient satisfaction and cost. And the primary interventions explored there were dressing and securement, flushing technique, and solution and remover schedules. Overall, there were no statistical differences in the analyses we were able to perform, and this was largely due to the small number of heterogeneous studies. And notably, only 17% of studies evaluated patient satisfaction or feedback. So here's just one of the main meta-analyses we were able to do on ultrasound-guided insertion, and we've thankfully been able to shift the understanding and knowledge in this area, but at the time, an analysis of pooled data on over 2,000 patients demonstrated that it made no difference to the first insertion success rates. However, this result has to be interpreted with caution because of the heterogeneity that we discussed, and mostly they were conducted in general pediatric or adult patients. There was one study that evaluated the impact of ultrasound-guided insertion on patients with difficult IV access. But I guess cautionary notes was this was often offered to new operators, and they only had a short course as a requirement before the training. And aids like ultrasound may not demonstrate superiority due to the complexity of the procedure, so operator experience really does have an impact on the rate and quality of IV cannulation. And so I think that's something to bear in mind. What you can see in a study or not see in a study, we've really got to make sure that that's transferable when we come to implementing it at a high level. So I think this small review of the studies available and the other reviews that have been conducted in this area have implications for making sure staff are well trained, educated and supported to use imaging guided insertion to optimise the results. If we looked at other interventions, there were some studies on near-infrared and guide wires and insertion site, different types and different models, but as you can see, very small numbers and results generally inconclusive. So all of this was really reinforcing that we needed more research on the area and more guidance. Another big area, almost a saturated area on insertion, was providing patients with analgesia on insertion. There were over 9 studies in the period that we were looking at, but and they looked at various analgesic agents from vapor coolant to lidocaine to Emla cream and other agents there listed on the slide, and also distraction therapies in the younger cohort. But 3 systematic reviews of studies that predated this review demonstrated the impact that some sort of analgesia had over no treatment. A meta-analysis of these studies did not demonstrate which anaesthetic was superior to another, and that vapocoolant was not found to be as effective as a treatment in children. However, overall pain is less if using any local anaesthetic or numbing agent compared to nothing, and some sort of pain relief should routinely be offered to patients for PIV association, and that gets the thumbs up from Sam Kerr and patients alike. So basically, the summary is there's been substantial studies on analgesia. No one agent is better than the other, but something is better than nothing. And we've asked patients repeatedly what it's like for them, and they've said it hurts, so let's make it not hurt. If we move on to maintenance, given the challenges of acquiring successful peripheral vascular access, which are really alluded to in the previous studies and perhaps through the experience as clinicians and or patients, I think it's vital to maintain the integrity and the performance of the device. So I was really surprised that there were still so few studies that evaluated how to maintain and support the IVs until the treatment is finished. And although many RCTs examined the insertion, then the maintenance was always secondary. Just 1/3 of studies reviewed and evaluated different interventions related to post-PIV insertion. So overall, the gaps identified in the research at the time are listed on the slide, but since then, colleagues have attempted to fill these gaps. So if we look at the importance of a vascular access specialist inserter or a team, I know that there's RCTs pending by Nicole Marsh and colleagues on this. If we look at catheter design, I know there's a recent large trial that's been published by Claire Rickard and team, and we've also got a systematic review and meta-analysis by Nicole Gavin and team. And I know that there's a new paper on preliminary catheter design by Barry Doyle and Caroline Shelverton as well. So there's been some significant research in that area since we first did this review and supported the development of the standard. If we look at the gap in optimal dressing and securement, I know that there's been RCTs, large and small, and systematic reviews led by Claire Rickard and Amanda Corley. If we consider the gaps in needless connected, there's also current and future RCTs pending, led by Nicole Marsh. And we also consider the decontamination to reduce the risk of infection. There's been preliminary studies led by Julie Flynn and also by Karen Slater and Claire Rickard. So it's really good to see that this is not a stagnant area, and that colleagues have really responded to the call to fill these gaps. And ongoing research by myself and Andrew Bulmer and others is looking to fill the gap on what is the optimal infusion and flushing regimes. And for future consideration, we want to consider the criteria for clinical assessment, and to some degree, Gillian Ray Burrell has developed the I Decided tool to systematically guide catheter assessment. And I know that Emily Larson and also Grace Zhu are very much looking at quantifying and partnering with patients to optimise their experience. So final thoughts. In summary, of the 40 trials identified 5 years ago, high quality PIVC trial was conducted and reported in the last 5 years. Billions of devices were used in healthcare settings globally, with billions of dollars spent on related projects. But there is little investment in quality research. So we need to, if we want quality outcomes and we want quality evidence, we need to invest in that. And really at that time, and to some degree it continues, clinicians and policymakers operate in an evidence vacuum, and that's why we wanted to summarise this, identify gaps, fill those gaps, but generate recommendations for where we did have evidence. So I think there is an onus, and there was an onus on government and the healthcare industry to invest in research. And further, I do think there was an onus on clinicians as healthcare professionals to value and implement the findings to improve patient outcomes and reduce the waste of healthcare resources. I think that's key for me, that we really need the clinicians to give these devices the credence that they deserve. Even though they're everyday doesn't mean they're insignificant. So in keeping with the sportings theme, we really need to show me the money and invest in quality research. We want core outcomes, so we reduce the heterogeneity across studies, and it allows us to pull results and make meaningful recommendations. We want meaningful, clinically related questions, and we want common goals. And importantly, we want implementation. And I think that'll be a lovely segue into Grace's talk. The recommendations that came out at the time, we were happy to tick some of those. The recommendation of the review was clearly to develop a national clinical standard. And fortunately, we were able to click that, and that's what was released in May 2021. So it was really good to fulfill that. They want the education and training of nursing and medical staff that focuses on contemporary and evidence-based PIVC insertion and maintenance care. And I don't know that we've absolutely got that, and that might be within the tertiary curricula, but also ongoing in the clinical sector. So it would be really good if we could really bed that down and make that consistent. We wanted evidence-based assessment for patients' need for vascular access and device type. We do feel that we have moved along that path, that the first question you ask, even in the standard, is does that patient need this device, and are there alternatives? Early referral to vascular access specialist teams and the use of imaging to minimise the trauma and optimise insertion success. I don't know that we've quite nailed that as a routine in our hospitals, and so I'll be really interested to hear from Callan and other healthcare providers about how we think we can make it that we don't have to have our patients repeatedly stuck and incurring unnecessary trauma, that we make it okay to escalate or consider alternative routes. We need to make routine, as I said, the use of analgesic agents or strategies to minimise PIV's insertion associated pain. We've asked the patients, young and old, they've all said it hurts, and there are many agents that we can use to relieve that, and we have the evidence to support that. Evidence-based clinical assessment, as I said, we've got Gillian Ray-Burrell's I-Decided tool and different variations on that. And so, and we know that the INS and CNSA and various other peak bodies give us comprehensive guidance on this. So that is out there for clinicians to access. Ongoing monitoring and reporting of PIVC use and outcomes. I know Claire and the Avatar team were keen to get a register up so that we could understand consistently and in real time how many IVs are in use, what the prevalence is, consistently what the outcomes are. And I still think that that is something that we could really invest in so that we can be more timely and responsive to IV care and the needs as they happen. And we can also see where we're making improvements and where we need to expend our energies to optimise care. And we definitely need to include the patient's views in all future research to optimise PIVC insertion and maintenance practices. And I'll be really interested to hear about the consumer on the panel today, Jemima. So I just wanted to thank the team who are all part of this, you know, such a big review and such a big process, in particular the Commission who responded to our calls, and that listed on the side of the people who assisted with the review of the guidelines and the trials. But with the actual standard, there were many key opinion leaders and many societies across Australia that were included, which is why we wanted to leverage off the Commission process. Because minimising patient harm, it's a national priority. To quote the US Institute of Healthcare Improvement in their 5 Million Lives campaign, if we do our job well, then the names of the patients whose lives we save can never be known. Our contribution will be what did not happen to them. So really that's what this is all about. And so thank you for listening, and I hope giving you that background helps you understand the importance of peripheral intravenous catheters in modern medicine and the importance of the standard, and we can find a way forward together in implementing them into practice to make sure that they perform the role they're intended to perform. Thanks.
Thank you so much, Samantha. That was a fascinating journey into how we got to this wonderful and very important and impactful national clinical standard that we have today. So thank you for all of your contribution. Did anyone have a question for Sam now? You can write it in the chat or put your hand up if you like. While you're thinking of your question, I'll just point out I'll put a link to the clinical care standard in the chat, as well as the actual 10 statements. there. I'm sure many of you are familiar with them already. Yes, Jemima.
I just want to know, can you hear me?
Yes, we can. That's very important. If no one else has a question, we will move on to our second speaker, and there will be time in our forum at the end to have a freewheeling discussion. So if something comes up that you want to ask Sam, she'll be back for the panel a little bit later. So our second speaker is Dr. Grace Zhu, who's going to speak to us about the current gaps in where we are in healthcare versus the clinical care standard. So Dr. Zhu is a Joint Research Fellow in Implementation Science with the School of Nursing at QUT and the Royal Brisbane and Women's Hospital. She is a senior nurse practitioner and a clinician researcher in emergency, and her interests include emergency care, implementation science, and vascular access. So thank you, Grace. I think Samantha, you might just need to unshare your slides, and then Grace can hopefully share hers in a seamless manner, and we can kick off. Thank you.
Thanks, Claire. Thank you for the lovely introduction, and it's such an honor to be invited to talk with you guys. I'm just going to share my screen. Hope you can all see my screen, as I can't really see you now. Okay, great, lovely, thank you so much. And so in the future 20 minutes, I'm going to share with you from a different perspective of how the standard get implemented in the real world, which is emergency department. As Claire introduced, I'm a nurse practitioner working in emergency department at Royal Brisbane, also QE2 Hospital. And so it is really, as a clinician, from my perspective, my interest is how we use best evidence in our real practice. So to start with, I just want to acknowledge the country and also acknowledge the other co-investigators like Professor Claire Ricard and Professor Amanda Allman and other teams who helped me to sort of roll over this project in the last 2 years. And to just declare a conflict of interest, this project received a grant from CERTA in Microsoft. So start with some data you already heard from Sam's presentation, which is Sam gave a very comprehensive background introduction about how the standard developed and also the overall landfill as well, and which is it's the first time I actually heard about it from a comprehensive perspective. I'm really amazed at the huge amount of effort being put into by the team and the community to make the standard available to Australian clinicians. And so to start with, I just also wanted to sort of point out, like, as we already know, like more than 70% of inpatient really require peripheral intravenous catheter in the inpatient environment. And 1 in 2 actually peripheral catheters get inserted in the emergency department, which is where I work as a clinician. And although there's obviously it's one of the very common sort of procedure considered as a manual procedure, everybody seems like able or need to learn and do as ED clinicians. And I found there's still a lot of suboptimal practice. For example, in emergency department, we found that first insertion failure rate is, especially with the patient population with difficult venous access, still quite high, up to 58%. And I guess really that's probably one of the reasons we want to know why it matters. It is because good PIVC care really matters from the perspective it's really going to sort of help to prompt sort of if we don't really do the good care, is that going to increase patient stress, dissatisfaction, delay their treatment, and also increase staff workload and also increase the cost of organization, which is proved by a lot of previous research, which I'm not going to touch on. And as Sam said earlier, in 2021, we sort of after 2 years of hard work, finally we introduced the first ever national clinical standards for the PIVC in Australia, which is really a milestone. And there's I just want to point out on the screen, you can see there's 10 sort of really standard indicators from the time of insertion to the time of how you're managing it, and then until the final bit, which is when should we remove it. So these 10 indicators really help us to decide what we should do at different stage, how we get measured as considered as good practice. So in 2022, we start off this project called Guide ED, and our research question is really quite straightforward because we know the standard has been sort of released to Australian clinicians. However, we don't really know whether our clinicians really know about it, what do they think about it, and do they really follow it? Therefore, we had some research questions really looking at ED clinicians' knowledge and attitude toward the standard. Do they think these standards useful or not useful? And do they really follow it or not following it? And also what factors sort of really impact on their practice? Sometimes, as we know, the evidence is there. That means the clinician will follow it. We want to know what factors really help them or really influence them making that decision in their practice. So this research this program really has 3 phases. The phase 1, we did a national survey that surveyed all the Australian ED doctor and nurses. And then phase 2, we did some audit, just want to say how people practice. And phase 3 is interviews. After we sort of triangulate the data from phase 1 and phase 2, we want to understand how clinicians, give them a chance to have a say about why they do or do not do certain things. So I'm going to just sort of show you briefly about this practice, these findings. So in the phase 1 of national survey, we conducted it on March to June 2022, and we used snowballing and sample sort of methodologies. And in this questionnaire, we really covered 3 aspects to look at their knowledge, their attitude, and also their practice. And then we used close-ended question and also ended question to collect the quantitative and qualitative data to understand it of many perspectives, a few perspectives, as you know, that 10 indicators, and from the insertion to removal. And just sort of want to point out so far, there's 1 publication of the quantitative part and being published in EMA early this year. The second part of a quality review of the open-ended question answers also is under review, and hopefully we can get to see the result. There are roughly 433 ED clinicians and responded, which is quite a good responding rate by having a survey like this. And we can say half of the clinicians or respondent are registered nurse, and with average of 10 years of experience, which is pretty good. And from the knowledge perspective, we found although half of respondents claimed that they were unfamiliar with the standards, participants demonstrated adequate knowledge of the standing sort of the recommendation and set the 10 standards and indicators. And I found this is very interesting findings when clinicians said they did not really know about the standards. And if we look at the background in Australia in the last 5 years, we know there's roughly 17 clinical standards get released, include sepsis, hip fracture, a few other things as well. And as a clinician myself, I feel like it is true we may not be having a chance to review or be aware of all these big fat documents, most of them quite long. And especially, I feel like our education is really focused or directed about educational team. If the education team providing a lot of promotion on that, therefore we will know about the particular thing. But otherwise, we may not even have a chance or capacity to looking at the standards ourselves. And however, as most of recommendations are built actually on years of well-accepted research evidence, as Sam just mentioned, the clinicians would still come across of some recommended sort of practice, as they sort of might not say them in other local guidelines as well. So again, I think this is really sort of saying we already accepted there's a lot of evidence in the standards, and it is based on years of sort of practice. And so eventually, we just need some more time and effort to help us to sort of emphasize on the education part. If you look at the attitude of the clinicians, and we found most respondents' attitude are quite positive. Apart from 2 areas, we found the conflict of the recommendations. And the first one is we found a quarter of participants disagreed of multiple insertion attempts were a common problem in emergency department. And it reflected an interesting thing, which is like seeing that culture of accepting of multiple insertion in ED setting is actually okay. Clinicians think, and if they need to have a cannula, therefore they just need to keep trying until they get one. So therefore they feel like keep trying, it is acceptable and it's a okay practice because that's what they do in a real practice. Second finding is 1/3 of participants disagreed like ongoing PIVC competency monitoring is necessary. Somebody's talking in the background. And they think there was no need to recheck the annual competency once they passed it. And in fact, and in other phase, which is especially the third phase of our interviews, we found, and actually not many hospitals monitoring the annual PIVC competencies. And although they all had to pass the first initial competency check when they were new to the department. So again, this is another area we sort of need to be sort of mindful. And from the practice perspective, and the self-reported practice was, there's again 4 areas like participants sort of reported that what they do may not be aligned with the recommendation in the standard. So for example, the catheter insertion, and 55% of participants sort of claimed, and they routinely insert of catheter due to complex reason, and which sounds like a good reason. For example, they feel like the ED environment is unpredictable, and patients have a high risk of deteriorations. They're not able to secure one when later on patient need one if they become really sick later on, and they won't have time to do it if patients sort of pass the first time they seeing them. And a lot of ED clinicians are very task oriented, and some of them even didn't even believe the 80% assured rules, which is we're trying to promote in the last few years, is really valid. And again, all these actually reflect in the interview as well. I'm sort of just going to combine them here while I'm telling them, because the survey data is actually telling really well aligned of the interview data, telling us the same issue. And the second thing is the ACF insertions. As we know, we're trying to avoid joint. However, 84% of clinicians feel like they still use ACF, as one of the main insertion point. And the reasons for because it is a big, easy sort of win they can get, as many of ED nurses actually don't have the skill to go for the more challenging wins, although they know some other areas better choices. And the third area is like we found inserters are really tend to insert without confidence, which means they will keep inserting, although they feel like I actually don't really know whether I'm gonna get it or not. They may even try twice, even though they feel like the chance of inserting the success is very low. The reasons for like they don't, some clinicians feel like they maybe should just keep trying just in case they get it, and they're worried about they're going to be judged if they don't try twice before they ask their colleagues to help them. And some of them feel like, the other colleagues are very busy as well, therefore they just got to sort of try to be mindful of other people's workload, therefore they try to manage themselves. And again, as the other cohorts, especially the clinicians who work in rural remote areas, they found they are the only inserted there, therefore they have no other backups. They got to keep trying because the patient needs catheter. The fourth area is lack of routine review of ongoing PIVC needs, which is another big issue, which is we already know, and it seems very uncommon, like ED clinicians think PIVC removal or even PIVC related task as a low priority. Therefore, they feel like they don't want to give much attention, and they just need to keep going to looking for look after the next sick patient rather than for only sort of looking at this one patient. And the top barriers from this particular survey shows like, firstly, unawareness of the standards, as we discussed this already. And second part is the recommendation. They feel like it's not very practical in the ED setting because the complexity and rationale I discussed earlier. So this is the other 2 areas, and we need to be sort of mindful. From the phase 2, the BEDSAT audit, and we sort of conducted in June to December 2022, we sort of did this audit in 3 metro source EDs in Brisbane, and the audit being done by the research nurse by following the patient and the clinicians at BEDSAT, and the audit really focused on like insertion, ongoing management, document, and remove this 4 aspects. We conducted 1,549 episode of audit. This is a breakdown of different episodes, how much we audited for, and most of the staff got audited are registered nurses, and they all very competent or expert sort of inserters. And although there's only 3% of the PIVC got inserted in emergency situation, which means in the resus or somewhere they need a really rapid, cannula get inserted straight away. We still found, unfortunately, 55% of the inserters did not really ask patient previous PIVC history, although they got plenty of time to ask them, but they just did not ask them. And 85% of the cannulas got inserted in the ACF or the wrist, which is equal to what we found in the survey. And another thing really interesting I found with the patient who identified was a DIVA patient. Although there's a 17% of patient identified a DIVA patient, only 7% used cannula, used ultrasound to help them to sort of navigate through, and 3% and escalated into the more experienced inserter. The rest of them, they just sort of kept trying until they get it, which is pretty bad for the patient care, unfortunately. And another things is, again, we found an issue of the area we also need attention is, for example, 56% of inserters did not wait for it dry after they use the clean wipes. They just insert it straight away. And 35% of insertions was labeled and dated, which means another 65% was not really labeled or dated at all. And the maintenance generally is actually not too bad, as you can see the result on the screen. And I'm just going to skip that. And the documentation is another area which is having a few concerns. For example, 37% of PIVC indication was not recorded at all. And 58% of times of insertion, which would I mean times of insertion, for example, they tried failed 3 times and nobody going to document that. Seems like only small amount of people will document how many times they failed, but most of them are not documented, unfortunately. And then only 3% of the removal date was recorded. Again, this is a reflect of the poor sort of documentation in practice in our ED setting. And from the removal perspective, we found 58% of PIVC has been used, and which means 42% of catheters are adult catheters. And 27% of PIVC likely to be used when they transfer to an inpatient. And however, another 73% of, again, PIVC is just sitting there without a really good rationale why we need them. Again, the reason for having a catheter cannula in place is just because, again, ED clinicians, they feel like if they don't really have a cannula when the patient gets transferred to the ward nurse is going to be not happy about them. One of the participants said, like, if the patient gets transferred without cannula, they're going to be aspired. So I think this is just reflect the culture of the whole hospital, not just the ED, because the ED clinicians' practice is impacted by their colleagues in the inpatient environment as well. And the phase 3 of the interviews, and again, we finished one-to-one interviews by involved 25 participants in multiple EDs, and we got 20 nurses, 5 doctors, include both junior and senior doctors and nurses, and with different sort of PIVC experience to increase the variability of these actual findings and the diversity of the finding as well. And again, because the time, I'm not going to go through details. Again, we sort of mapped out the COMBI and TDF, which is an implementation framework, to help us identify the barrier and facilitators of how to change the settings, how to change the issues and overcome the issues, and also help us to develop some potential strategy to address the issues, some of the issues, not all of them. And just sort of summarize very quickly about area of improvement by mapping the survey and audit data together. As you can see, there's several areas of we need to improve, which is not work really well. And both survey and audit data, even the interview data, they all sort of equal each other, saying this is the same problems from the insertion to the documentation, also review needs of whether we should remove it early as possible. And as a conclusion, I just want to say on the standard, it is great we have such an amazing clinical standard available to the clinicians. And however, as you can see, the complexity of individual settings, and therefore when we interpret the actual recommendations, and we need to contextualize into our individual environment. And as you also say, although there's a lot of effort being put in there to help the disseminate of the findings and recommendations, it is still quite a challenge. And having the standard available alone is not going to be sufficient to change the practice based on our previous experience, not only for the PIVC guidelines and also for many other standard and guideline available. As we know, our clinicians just not really following them due to complex reasons. So therefore, it is quite meaningful and to develop appropriate strategies and interventions to overcome these barriers, which is what we support. We are actually in the middle of planning for as the next follow-up stage and to sort of contextualize some of the recommendations into particular standards based on the need. This is my contact. If anyone's interested to know more about this funding or want to know about the publications, I'm happy to share that with you. Thank you so much. I'm going to stop sharing.
Thank you so much, Grace. That was really insightful and such a good project to go out and actually look at how the standards can be prioritised and implemented based on the current practice. And ED is such an important area for PIVCs. As we know, probably half, would you agree, of the catheters go in the hospital in ED? You would. So we might move on to our panel now, and those that have questions for Grace, we can include those as part of the panel questions, I think. So we would like to welcome back Professor Samantha Keogh, as well as keeping Dr. Grace Zhu on our panel, but we'd like to add two additional excellent panel members. Firstly is Jemima Fritz, who is a consumer. Jemima has lived experience of vascular access, including long-term central venous access devices used daily for IV fluids and TPN. She enjoys bringing her experiences as a consumer as well as a registered nurse to her work with the Wiser Wounds group to provide input into research priorities and projects that can support other consumers and improve the health system. So welcome, Jemima. We're also very fortunate to have Mr. Callan Batley here. Callan is the Executive Director of Nursing Services at Children's Health Queensland. Callan is passionate about the healthcare and wellbeing of children and young people, particularly in equity and quality and safety. He has conjoint roles in partnership with many universities to develop paediatric and young people nursing workforce for the future, and Callan is actively involved in many research projects to improve care and outcomes for children and young people. So thank you for joining us, Callan. We know your diary would be very busy as well. So I'm just wondering if anyone would like to start us off with a question, either by raising your hand or in the chat. We've got probably a lot of things we could cover, but only just 15 minutes to do so. Otherwise, I'll start off with a question, and people, please feel free to join in or type them in as you wish. So we'll start with you, Jemima. Thank you for joining us today. We're just so overjoyed that we have your expertise, because it is just so important that we include consumers in everything we do. Would you like to perhaps just talk about your experiences with peripheral IV catheters and any thoughts on the new standard?
Yeah, hi everybody. I'm kind of, thanks for having me here. I really enjoyed what the research was saying and all the work everyone's doing. From a patient's perspective, it makes a difference knowing that, you know, there are standards out there and that people are trying to make changes to make it better from, you know, the patient's side. I think there are a couple of things, if it's okay, if I made some notes. Is that all right?
Absolutely. We're all fascinated to hear what you think.
I kind of picked up on a couple of things that I thought might really help, you know, kind of help the patient side of things from patient perspective, taking kind of a nurse hat off for a sec, is, well, maybe not my nurse hat, both. It feels like when you're in the bed and you've come into, say, ED, or you're on the ward, or, you know, something like that, it kind of feels like the patient is a guinea pig to the junior doctors coming in and just getting their IV access, you know, and this, you know, continued, oh, we'll just continue to keep trying, you know, from an RN's perspective, you know, some days you just don't have it. And some patients, you just don't have it. And it doesn't matter how many times you stick them, you know, that unless it's an emergency, I'm just talking not, you know, normal admissions or coming into ward or whatever, you know, sometimes it isn't helpful for the patient to have someone just continue to keep trying. And it also adds to, you know, our trauma, our medical trauma, but also to each time that happens, we lose our voice. You know, that we feel like, you know, because we're so reliant on the people that are taking care of us to sit back and, you know, to say, stop, you're hurting me, this is too many times, you know, get somebody else, you know, to have someone turn around and say, we don't have anyone else. And I live in Alice Springs, so, you know, I have remote, I've been in cities and I've worked in large hospitals around the world and also here in Alice Springs. And I'm sorry, having the excuse of we don't have enough staff isn't good enough for a patient. As the RN, I understand that side, but that's not good enough for a patient, because, you know, we need that continuity of care. We need people to support each other in the environment of the hospital that we're going to. And so, yeah, it can feel very disempowering to have junior doctors thrown at you, you know, who continue to keep trying, who, you know, and who don't ask questions. That does make a, you know, what is your IV access like? What is your history like? You know, not having the training for using ultrasounds, not having the training for, you know, sometimes all they ever go for is your AC, you know, knowing that they can use the hand. What about these sections in your arms? You know, when I was working in NICU, you know, a lot of the nurses didn't know how to go in the head, you know, like there's all these things that add to, you know, and they don't even know about sucrose, I'm sorry, but, you know, giving little babies sucrose and things like that. So I think that there's a lack in the training and then in being able to admit that, you know. The other thing I was going to say was, because I've done a lot of IVs as a nurse, been on the other side, but, you know, having lidocaine, you know, an injection of lidocaine can be just as painful sometimes for anything under, you know, under a 20 gauge. And that can be quite traumatizing as well, because there are a large amount of people that you can use it. If they don't know where to put it, it doesn't necessarily mean it's going to work. You know, they you know, they may numb the other part of the hand and not the part that they're trying to go for. You know, these things happen regularly. The other thing was, a lot of them don't know how to get veins up. You know, it's not, sometimes it's not as simple as just going, come on, you know, we'll just move more alcohol. You know, there are other ways to help the veins come to the surface, you know, looking at hydrating. Obviously not an emergency. In emergency, we're talking a very different situation, right? It's get in, get out, get it as quick as you can. But so yeah, so I was kind of trying to say it's not acceptable from a patient's perspective to have someone keep trying, throwing junior doctors at them when there are trained nurses, you know, having areas of the hospital that don't have training, you know, like in the wards, I think there should always be people that are on that know how to do IVs and confidently, you know, because they're scrambling at the last minute, trying to call down to ED, ICUs, you know, whoever, to get someone, which doesn't help a patient feel confident nor feel that they're getting really good care. And then also too, the confidence, it's okay. I think that's the hard part, is getting the culture out there to say it is okay to ask for help. It is okay to say, I don't feel confident. It's okay to say, I haven't had the training in ultrasound, or I don't, you know, really know what to do in this environment, or instead of just sticking in a room and constantly keep going. I really picked up on that from Grace's, you know, stuff that she was saying. Especially the junior doctors, you know, the nurses maybe rely on each other a bit more, but the junior doctors are like, I have to know this, part of my training, you know, this is really important. I can't let the team down, you know, whatever. And then documentation. I think there is a massive lack of documentation of when they go in, how many attempts, when they're coming out, you know, what they're being used for, you know, and that's across the board, I think, doctors and nurses. And that does, because we do ask, you know, we say, hey, I think I've had this in 3 days, or how long has it been in? Sometimes they don't write it on, you know, the IV, you know, or there are policies and procedures, and, you know, different hospitals using different policies and procedures of keeping longer than 72 hours, only having 72 hours, whether they go to ward with it or don't. And then the other,
can I just stop you there for 1 minute, because I think you're just bringing up so many wonderful things, and we'll definitely come back to you for your other thoughts. Is that okay?
One last thing.
One more.
I was just going to say that patient advocates at the hospital are brilliant to go to for information, because that's the first place a patient will go if they have a complaint, or if something hasn't gone right, or they are going to be the ones that are really going to help you get your information. And that was all I was going to say.
Perfect. And very good advocacy there to let me make you finish. Yeah. Well done. I think that's really, it confronts us and it challenges us, but they're really excellent. And I guess perfect segue to go to you, Callan, as an executive member of the hospital. How do you see dealing with these sort of challenges about staff repeated insertions, not just nursing, but also medical, improving the patient's perspective that we do actually have the ability to provide high quality insertion services?
Yeah, Jemima, you've hit so many notes that we would hear in a paediatric setting regularly. We probably have two sorts of consumers, Claire, like a really experienced parent and child that might be in our service regularly, and so they're quite knowledgeable. But we also have people who might have their first interaction with healthcare and therefore cannulation in like an emergency department. So, and certainly what I think we really need is a bit of a cultural shift in healthcare. You mentioned about training. My first cannula was inserted on a ventilated snake bite victim in a hospital where, because they were ventilated, it was seen as good training. And that was sort of very much a way where I think we've got into a habit in healthcare of simplifying something that's uncomfortable and memorable, and actually can be done better with less harm. But because it's been simplified, I think it's seen as a training opportunity for quite junior staff. And just yesterday, Trish, who I know is one of our nurse practitioners, is one of our awesome nurse practitioners at CHQ, and I were just talking about the cultural shift needed within our staff to really treat every cannulation attempt and every cannula management opportunity as a precious moment in the system. And I think that also speaks to educating our consumers who may not know any better. They might expect discomfort or expect to have a cannula recited. And so for me, one of the things that I think in my own hospital, which is up here in Brizzy, we need to do is really shift that cultural thinking that this is a beginner's skill to learn, and actually people should experience a degree of discomfort and potentially multiple attempts. I think there needs to be a level of importance placed on it that I think forces us as a healthcare system to, Grace, to your point, escalate early, use the appropriate device as an adjunct to support cannulation, and for every person who is looking after that cannula from then on to really treat it as precious. So documentation being, highly compliant. And I think that constantly reinforces to, in my case, a parent and a child, this is really precious, and we need to care for it. But I think, unfortunately, we also see lots of people, including, I hate to say it myself, of my vintage, when I had my first cannula ever put in, it sort of, I almost expected pain, and I expected there to be, it was a bit of a hassle, it was treated as something that might fall out and might need to be recited.
Thanks, Callan. We might go to the chat. There's a few questions there. Jonathan from Western Sydney has suggested, why don't we have a nationalised standard training just like we do for BLS, ALS and so on? I don't know of anything equivalent at the moment, but would the panel like to talk about, as part of implementation of the standard, do you see that this is perhaps going to be necessary?
I'll comment. I thought that was a good suggestion. I know there was another comment in the thread that talked about every ward should have education, key performance indicators. I think education alone isn't the only thing, and I see Grace nodding. We've really got to change hearts and minds, as Callan and Jemima have said. We've got to help people appreciate how precious and important this device is. I think there needs to raise awareness about the need for vessel health preservation, particularly when people have it across their lifespan. And as the most common invasive medical devices we identified, we need to both raise awareness about it, how important it is, the potential risks of this everyday device, and then help them access the guidelines. And maybe having that as part of routine mandatory education will help reinforce that.
I just want to add on very quickly on that. Sam said, I think another thing I didn't mention, I think is very useful is because there's no ongoing monitoring about the consequence of individual insertion. Therefore, for example, we insert a lot of cannulas in ED. However, because we never see this patient anymore, they may have sepsis, they may have whatever, but we don't know as an individual. Because of that link is broken. Therefore, there's no responsibility can be tapped into individual behavior. I think that apart from education, really need some sort of monitoring system and to put in place to keep this monitoring. Therefore, can give really useful and relevant, meaningful feedbacks. Thanks.
Yes, as part of the standard, they did develop some potential indicators that healthcare institutions can use to try and assess where they're at with adherence and to monitor improvements. If people are interested, go and have a look at those. I guess I wanted to come back to, Jemima, your point about the the consumer advocacy and how we sort of encourage that more. And obviously that was on the Commission's mind because the standard does have one of the standards. In fact, the second one should be number one, shouldn't it? Consumers inform and partner with patients. Do you have any thoughts, Jemima, on how we can better make sure that that does happen as more of a standard?
Meaning the standard be people being able to use that patient advocacy?
Yeah, I guess that they've specifically said about ensuring that we give information and education to consumers about their reason for their cannula, that they can help partner to prevent infections and other complications, as well as ensuring there is actually consent and preferences such as location of insertion and so on. But I guess it all comes back to your thoughts around advocacy and how perhaps we could encourage more consumers to advocate or to encourage staff to listen to them when they do.
I think it's, from a patient's perspective, I find a lot of people are talking about the posters that are now showing up in a lot of rooms that weren't showing up previously. And I even myself noticed them, people, sitting in surgical ward or waiting to, have a surgery, they walk along and they read the posters, sitting in the room, and, things like Ryan's Rule, and a lot of those people are talking about those, not just online, but they're reading the posters and stuff. And having that, I think there needs to be cues that empowering patients to be able to speak up for themselves, that you aren't going to be ridiculed, that you aren't, that there is information that you can give us that is really important to helping us give you really good care. And that also, I think, cues the doctors and the nurses and whoever to be able to, stop, because we get in our heads, right? We've got one patient, we've got to do this, I think it allows them also to come back and see the person standing in front of them and, oh, this person, I need to give them the attention right now. I think the posters really do help in having quick, fast, simple cues for the medical professionals and for the patients. And then also knowing from a patient's perspective, if I have a complaint, it will be heard. It's not going to be dismissed. And I don't have to go all the way to, patient advocacy for the hospital and then, the fear around somebody being, reprimanded or whatever, that it's the reassurance on the patient that medical gaslighting and, bad situations don't have to happen, that they do have a voice and that they can communicate, even if you just, because sometimes it's hard. As a patient, it's hard.
Absolutely, totally agree. I think one of the audit indicators for the standard is to actually go around and ask patients, do you know why you have this cannula? Which sounds like, you would hope you would get 100% answers from patients who can answer or their carers. But unfortunately, we know that isn't always the case.
I was just
Helen,
going to say, in response to that, just what you just said there, in response to that, it's kind of expected when you go to the hospital into an ED, you're going to get a cannula. Like and I mean, I've worked in America and I've worked in Australia. It's kind of like you go to ED and this is what happens, right? And I think on the ward, there isn't that expectation, that kind of might throw them off.
Thanks, Jemima. I'm conscious we need to wrap up in a sec because everybody's got to run back to their other real jobs or their patients or wherever they are for the rest of the day. So I might just ask Callan, in terms of implementation of the standard, what have you found to be the biggest challenges, as well as maybe what are some easy wins in terms of implementation?
I think sort of the three things that come to mind. I mean, the national standards are still relatively new when you compare national standards in other industries. So, you know, anyone of my sort of generation that's sort of approaching sort of an age with a 50 in it, the standards have changed. So there's still a number of clinicians who aren't super familiar, like haven't grown up learning these through their undergraduate degree, for example. I think they were launched at a time during a pandemic, which is really tricky for any new care standard, because I think people who really needed to know about these standards, like say, Jemima's mentioned emergency, like, you know, frontline, we've got about 250 odd admissions a day through our ED. I'm not sure how many get cannulas, but maybe a significant amount. Just during that last 3 years, it's been a tricky time for care standards to take a real foothold with clinicians when there's been a fairly large distraction. I think the other thing, though, that's happened, which is probably, I mean, I'm seeing really relevant to all standards, not just this one, is probably a shift from, I think, like towards individualism, where standards and rules are kind of, and an environment where we have a very highly specialised workforce in my place of work, there's been a real push away from collectivism, and that's a real shame, because I think actually, you know, that's, I certainly see that in some of my staff around, you know, wanting to follow rules, etc., requires much more effort of force to try and push them. However, that being said, I look at the comments about CPR and it's got me thinking about training, because that's something that's kind of, it's almost beyond a standard. It's just accepted now. It's not even about mandatory training. Wherever you work, there is a certain level of competence you need to do this. And I think, but I also think the flip side is we've seen a lot of improvements from standards in other areas. So for me personally, I think there are a few challenges there about getting people on board with any standard. I think, and we're going to see more and more individualism. I think we're seeing it certainly in the US and in Australia a lot around people trying to get policies adhered to. But I think the hearts and mind piece that Sam mentioned, and I really believe strongly is important, is probably starts with listening to those consumers and making that first moment with a patient who might be their first cannula. You know, an ED presentation would be a great example, where a clinician takes that extra bit of time to sit down and really make that an important attempt and educational opportunity for the family. I think for us though, Claire, I think the great thing is we are accredited to this. So accreditors are making it harder to get through an accreditation process in my sort of 20 years of being an executive nurse than they were 10 or 15 years ago. So we really do think that if you've got gaps or if you're not working towards improvements towards this standard, it will be picked up by your accreditors. So that's an important accountability, I think, to have. But I think the big thing is, I mean, for us, how do we win the hearts and minds is my challenge, because in my world, and I'm sure like every healthcare professional, there's lots of really important things to improve. But for me, this feels like a really easy one. And actually, this is a very elegant care standard. Actually, it's not as complicated as others. And there are many that are really tricky and layered. And actually, it's interesting how it sits beautifully across all age categories. There's a lot of national standards like delirium that don't sit as beautifully in children as they do for older adults. But this is a standard where it's really quite universal, I think, and it's not sort of discriminate to different services, large or small. So so thanks for all of you for writing it. But I suppose, yeah, there are some challenges there in getting it hardwired into practice. But I think one of the ingredients that we've found really useful for all of the other national standards and care standards has been persistent. I think you've just got to sort of continue to see those iterative changes and improvements towards reaching that utopic goal of getting it right every time and repeatedly getting it right.
Thank you. Well, that's a wonderful note to end on. Let's go with the aspiration and the dream and the vision. And I agree, if we keep being persistent, then we will improve things and overcome some of these challenges. So our time together has come to an end. I'd like to thank our speakers, Professor Samantha Keogh, Dr. Grace Sue, and our panel members, Jemima Fritz and Callan Batley. I'd also like to thank our organising committee behind the scenes, so Stephanie Hall. And I said Stephanie Pitts, for those of you who know Stephanie Hall, Helen Liu, Professor Amanda Ullman, who've all been putting in the time to get this organised for you today. And just to refer you to the Australian Commission on Safety and Quality in Healthcare website, if you Google Management of Peripheral IV Catheter Clinical Care Standard, or the link is way up in the chat there, to know more. We also have a range of resources at the Avatar Group website, which is in the chat as well, if you're looking for other advice on peripheral IV catheters. So thank you all very much for joining us today, and wishing you a fantastic rest of your day. Thanks.
Thanks, everybody.
Thank you.
Thank you. Bye.
Thank you.
Thanks. Bye.
Bye, everyone.
Thanks, Steph. You did a great job. It all came together. Well done, Claire. Yay. Tick.
Tick.
See you guys soon. I've got to run to my 1 o'clock. See ya.
Thanks, guys. Bye.